Thank you, everybody, for joining us today. Today's topic at hand is to discuss difficult conversations, specifically in the setting of our hepatitis B patients. My name is Jennifer Geremia. I'm a physician assistant in gastroenterology and hepatology at Brigham and Women's Hospital in Boston, and I've been in practice now in GI for 18 years.
My name is Andrea Keller. I am also a physician assistant. I work with MedStar Georgetown University Hospital in the transplant department. I primarily do just hepatology disease and have been practicing for 16 years. The practice in which I am in is heavily dominated by hepatitis B, so I think this is going to be a great topic.
Thank you, Andrea. So let's sort of kick us off here. Can you speak to how you navigate the conversations with your patients regarding cultural sensitivity and health literacy given this complex disease state?
So, hepatitis B, or if you don't know, I should say, is predominantly a family disease, really. It is technically or used to be considered an STI. I know it still is, but in the settings in which we see it, it tends to be groups in families. A lot of our immigrant patients, those that, have migrated to the United States because their grandfather came from years ago. And I think a lot of it, not even just cultural, but there's a language barrier. There's, financial issues. A lot of them don't understand insurance that they don't even understand. So I think it's starting very small and then, answering their questions, listening to them validly, and then saying, okay, well, this is what I can offer you. This is what I want to do. Please let me know your questions and concerns, and then involving everybody together in the decisions that you're making, not just the patient, but of course their family as well.
Great.
How about you? In your practice, how do you do things like this?
No, completely agreed. I think, sort of educating on how this disease sort of is transmitted and understanding sort of their concerns in not potentially seeking out care or being afraid of what the implications of having the condition is, and just sort of reinforcing for them that we do have therapies and that we are here to support them and, their family as well. Kind of pivoting off of that, there is some stigma, I think, associated with the word hepatitis in general. And as you alluded to before, right, it's still sort of part of the STI list. But I think also in the world of hepatitis C, there's some, connotations potentially that the patient, through their behaviors, contracted this illness. And yes, we know it is a bloodborne pathogen that can transmit through familial contact, through, perinatal transmission. And we'll, discuss all of that. But I think also kind of breaking some of those misconceptions for them, that it's not their fault, and irregardless of how they transmitted it, that we're here to help to support them and to keep them healthy. Because if that's not done, kind of what the downstream complications are of not having adequate monitoring and treatment when indicated. I think also too, using the term living with, because we can't cure this condition, right? Like yes, we can with Hep C. So that, can be a bit deflating or disappointing to the patient. But if we just, again, reinforce the ability to support them and, hey, we're going to get through this, even though it may be a long-term commitment to therapy to keep you and your liver healthy here. And certainly if they're open to, support groups or in their region or even online forums, to try to have them feel like they have a network of support and that they're not sort of alone in this process.
Yeah. I also have found, and like I said, I see a lot of hepatitis B. I have found that although family members come with their patient to help translate, even telling them that I have the ability to bring a translator in, I think sometimes breaks some of that fear. They're coming to a practice where they're standing in front of a white girl to say, hey, you have hepatitis B because you were born in Vietnam. Let's go through the story. They don't get all the pieces. And even the family members, when they're translating, are they getting all the right information? So I make sure they just feel comfortable. And again, this is a lifelong commitment thing. We're going to do it together. It doesn't matter how you got it. We know it's there. Now let's address it.
Absolutely. So, Andrew, if you can sort of on that kind of spinning off of that, how do you navigate sort of the long-term management and adherence needed for a condition like this? Because often we don't want to lose the patient, and then we're left with potentially end-stage liver disease and cirrhosis, and they're definitely needing to see you in a transplant, potential capacity. So how do you help to navigate that?
Well, the first thing, obviously, is making sure they understand that this is a chronic disease. There is no cure. The treatments we're offering are suppressive managements, so they are purely there to control everything. The minute that medicine goes away, the virus does come right back. And then, again, reinforcing, we're going to see each other twice a year. We're going to do this twice a year. I'm going to follow you for a long time. Bring the rest of your family. I mean, I think we should screen everybody and work together. I try not to scare them enough to be like, oh, if you miss a pill, you're going to die, because that's not necessarily the case. But yeah, making sure they're very rigid about it, particularly if it involves, taking medication every day, just like a vitamin, or, you have high blood pressure, you take your blood pressure pills every day. Same idea. We have to take our hepatitis B medications every day. Oftentimes encouraging them to say, hey, if you can control the virus in your own body, we know that you're not going to spread it to anyone else. And I think that's a huge motivator for a lot of people, particularly when you live in a family, you're protecting your children and you're protecting your spouse, encouraging the rest of the family to partake in it as well by getting vaccinated or ensuring that their vaccines are up to date. But yeah, I just at the outset say, this is the plan. This is how it works. We're going to do this for a long time. We're going to be working together for a while. So let's get familiar with each other. But from the most part, most everybody is pretty good. You have those few that, always are a little bit forgetful, but, I just ensuring that they understand it's okay to miss a pill, but let's try not to if we can avoid it.
Absolutely.
How about you? Same-ish?
Kind of with that, agreed. I think one thing I sometimes throw in there as well, and it's not to scare the patient, but if they're really kind of lackadaisical about taking their meds, that we do worry about potentially resistant strains. And it's not that we can't then treat them, but it certainly just complicates their overall course, just to try, kind of just like you would tell a patient who needed to take antibiotics for recurrent UTIs or pneumonias. Exactly. Or, that, we don't want there to be a resistant strain develop, complicating your course. And I think sometimes just impresses upon, hopefully not in a fearful way, sort of the need for proper compliance with their therapy. And, also to just the compliance with the lab monitoring, not just for sort of viral load, but also to, creatinine, depending on which, medication we're using, et cetera. Just that, they can be very helpful to keep them healthy, but we do need to monitor them for, potential other events, just like you would for cholesterol. So kind of likening it to more common conditions that they can kind of relate to more readily, I think is helpful. I think, another kind of hot topic here is sort of perinatal delivery, phases of potentially infecting their newborn, which can be very, very scary, is sort of another sort of area of vertical transmission and kind of family planning. And I think in my own personal experience, regardless of sort of someone's immigration status, that just OB-GYNs are well educated on this and know what labs they're ordering, because the lab tests, right, are such a wide swath in terms of identifying immunity versus active infection and not creating undue stress on, mom and family. So I think that's also another area that needs a lot of education. And I'm just curious, how do you have that conversation with either people of childbearing age or someone potentially who is family planning around this kind of difficult topic?
Some of it depends, in a tertiary care center, I often get referrals from OB just to say, hey, look, my mom tested positive for surface antigen. What do you want to do? And of course, we run the gamut of the additional labs that are missing, and then you educate mom and say, hey, look, you have a viral disease. Yes, you are sharing a blood supply with your fetus. That is very likely that your child could potentially contract this. Our goal is to protect you in as much as we're protecting them. If they're doing fine initially, we watch them, as you know, because, we don't want to nobody ever really wants to start a new medication within the very first few months of conception anyway. So usually it's in the second trimester if the mother's labs start to change or if their viral load really starts to take off. Our ultimate goal is to drop that load as low as possible before delivery. It may not be negative, but as low as possible. And these medications that we're using are safe for pregnancy. They are safe for lactation as far as we know, although, there's not a ton of studies out there. But I will say, encouraging them to tell them, this is not, you're not doing anything wrong. We can protect your children. Your children can be born without this disorder. And then reminding them and OB as well as peds about HBIG, which is the immunoglobulin the baby will receive immediately, and then immediately starting them and being very rigid and consistent with their hepatitis B vaccination series. If mom and dad have Hep B and are completely viral controlled, the likelihood of their children contracting disease is virtually zero. It's those that are not, or those that are lackadaisical with their therapy, that there is the risk. I will also say there are pediatric gastroenterologists. I am not one. We don't treat them here in our practice that also treat hepatitis B. So it's not like your children are going to have this thing and nobody's going to know what to do about it. There are good providers who know what to do, and medications are approved for children down to age 2. So, there are a lot of options. It's not a death sentence. It's not do or die. It's just, you now know this information. Let's try and keep everybody safe and healthy in the right way. The monitoring is a bit different. So I try and encourage them to be very strict about that and work very closely with their OB. God forbid there are any questions or concerns as things change. But yeah, it's a touchy subject. I'll be honest. I often write a lot of letters for infertility clinics around here because, if dad already knows he has Hep B, or if mom already knows they have Hep B and they're going through the fertility management, the fertility clinics are asking that we kind of sign off to say, okay, everybody is well aware of this. We are understanding the risks. We are willing to take that on. I don't necessarily think that's fair, but we do it. And it's true, as long as we're managed and they're doing really well, there are no complications in pregnancy that will develop directly as a result of this. They can have vaginal births, C-section births. They can do whatever they need to do like a normal woman. It's just that they have this other entity we have to deal with.
Absolutely. I think too, when we meet, collectively, maybe someone is not immediately yet pregnant, but if they're not vaccinated, right, kind of getting them vaccinated if their households,
yes.
Obviously we know what proper vaccination is based on childhood schedules or even adult schedules now up to the age of 59, but, maybe they didn't have that available to them, or, they weren't even aware that it existed. So I think obviously, especially in this day and age of, some vaccine hesitancy, really revisiting that conversation, that is one of the best tools that we have to keep them and any potential offspring, healthy, of course. I think also too, breastfeeding is a common concern, right? Like if I am positive, even if we go through sort of the iterations of whatever that pregnancy or baby needs, that they are able to also go on and breastfeed, which I think sometimes is a misconception of whether or not that is reasonable thing to do, as far as keeping, the baby safe, and certainly they can. So this, I think, is one of the more challenging conversations, certainly, that we have with our patients.
Yeah. I also think it sounds really silly, but documentation is really important because they hear what you say, but not always do they listen to what you're saying. And if you document it and, provide like a small summary to them at the end of the visit to say, hey, these are the things we discussed, these are the things we recommend, and then making sure their gynecologist and obstetrician get that information, I think that calms them down a little bit enough to say, well, she said this, and I swear I heard this, enough to say, okay, well, no, this is what we discussed, and, you'll be okay, and pregnancy is not off the table, and all of that.
Absolutely.
How do you, and again, kind of random, screening, long-term screening. I know we talk about medications being a long-term thing for these patients, but there are risks with hepatitis B. And how do you discuss, especially with our young people, those that are in their early 20s, just kind of starting out, some of them are still in school. How do you impress on them the importance of screening and how regular and I don't want to say regimented, but it kind of is that we recommend they do these screening exams?
Absolutely. And I think that's true for any chronic illness, GI or otherwise, right, that needs monitoring. If they are kind of regionally where you are, I'm also in tertiary care. We have a lot of colleges and schools around here. So it's sometimes navigating where they live versus where they're going to school. Are they an international, student, et cetera. So I think, kind of meeting them halfway in ways that are tangible. So, virtual visits as a way of a touch point, if that's feasible based on payer and sort of logistics. But I think that can be an easy way to touch point with them. Okay, maybe they can't have their lab at our facility, they're going to be at a different place or what have you, giving them an order that potentially they can take to a lab closer to home. If that's easier, again, suboptimal in terms of getting results and you want to keep things consistent with the lab, but just trying to kind of meet them halfway. I mean, if they are on any type of medications, even if it's not Hep B specific, perhaps they have concomitant GERD or some other condition, I sort of use that as a barometer. I don't give them 11 refills. I'll use that as like a touch point and say, okay, I got a refill request. Has this patient been compliant with X, Y, and Z? But as far as impressing upon them, again, I think it's always the balance between, reinforcing the need for compliance without scaring them about something that can potentially be an issue. So, just reassurance, say, hey, if we do this and, we monitor you and we catch things at a point that's early enough, then we can intervene versus it, getting ahead of us. And then it's, things are much more advanced in terms of the health of your liver and the ability to keep you healthy, I think is helpful. And especially with the younger generation, they're inclined to, use resources online, just directing them to the right places versus just sort of arbitrary social media sites. I'll give them the tools and say, I tell them, education is power for you. I want you to delve into this. I want you to learn, but I will give you those resources, whether that be, a certain, foundation or whatever the case may be, but not just, sort of Dr. Google. And then that sometimes can scare them off and kind of having that dialogue.
Absolutely. Yeah. And again, because a lot of these patients come with families that also have hepatitis B, just setting it out in the beginning to say, okay, well, dad has it, grandpa had liver cancer. Let's make sure you never go through what grandpa had to do, or let's make sure you don't develop cirrhosis like your dad, so we can do a little less MRIing over time and more sonogramming. I just think keeping the communication from the very beginning really simple, really easy for them to grasp onto, and then always just being available, for questions or, the nuances of, oh my God, I forgot to take my pill today. Should I take 2 instead? Just to say, hey, you don't have to panic. You'll be okay. Simple things. Giving them the reassurance that they know what they're doing, even in spite of having to have and deal with this for the rest of their lives.
And it's, exciting to have different resources and ability to talk about this. I think, for a long time, we've known about hepatitis B, but maybe never had the discussions that we needed to. And so I think the more, it's out there and the more that patients see that they're not alone in sort of this journey, may not normalize it for them, but at least gives them some confidence that they're not sort of the lone soldier fighting the fight in the midst of the weeds here, because they can get sort of closed off, lost to follow up because they think it, there's no point or I'm doomed to be like grandpa kind of situation. So taking that time to have that education and, if it's faced with treatment or, not treatment, not everybody may buy into that, and what are sort of the advantages and that shared decision making of starting on the path to treatment and why we're recommending it based on, serologies, biopsy, whatever, metric we're looking at, that, okay, the active inflammation and kind of what those risk factors go along with and what that mean in the long term, especially for a while, like they have been monitored and now suddenly something may have converted or God forbid, they may seroconverted on their own, but now they're diagnosed with another unassociated malignancy or they have another autoimmune condition and they're on immunosuppressants and they fail to tell us that because they have a new disease. And so just letting, I think another kind of thing that I say in these situations is, if something else comes up, just let me know. Keep me in the loop, whether that be a portal message or, don't assume I don't want to know, because there will be other health conditions, other medications that'll affect your hepatitis B status or your therapy. And we need to know that because that can have other consequences. I'm not going to treat the other condition, but I'd like to know about it so that we can all kind of work in tandem. And I always also reiterate, let your other providers know, hey, this is, I carry this diagnosis, so that they can make the appropriate decisions in terms of management for these other concomitant diseases as well.
Yes, agreed. I think, again, that stigma thing, going all the way back, a lot of patients don't like to tell other people other things. And again, culturally, a lot of the groups of people that we're going to see don't talk about health. They don't
at all.
They don't ask questions. They go to holistic providers. They believe that if you take this tea or this herb, it's going to make it better. So I think there's a lot of behind the scenes, I'm doing all of this and nobody really knows that I'm doing it because I'm totally normal on the outside. And I think encouraging them to be more forthcoming, for their own protection, for their providers' protection, for their families' protection. And then, helping them understand that viral disease has changed very drastically in the last few years from all accounts. We are learning a lot more and more every day about many things that we thought were literal death sentences upon diagnosis. We've learned a lot about COVID-19, and HIV is changing, and hepatitis C has drastically changed. So, I mean, it's good to be here now as opposed to 20 years ago. But it is still something we have to deal with every day. And as long as we've helped them find the confidence to understand their health and their condition, I think many of them do very well.
Absolutely.
Any other interesting topics for hepatitis B or conversations you want to potentially share with others?
So for those of you listening, I think to my earlier point, just knowing what serologies you're ordering and when. We don't expect that every PCP, every GYN, every even general GI provider is going to be able to navigate the world of hepatitis C serologies. But I think just as an example, I had a patient once who was sent to me who was surface antibody positive, and their GYN told her she was pregnant, that she had been exposed to Hep B, and clearly created a lot of upset for the patient, her spouse, and the entire situation. And needless, because whether it be they ordered the incomplete panel, or they don't necessarily weren't paying attention to picking antibody versus antigen, or both. But just I think if you don't know, refer to those that do. If you are just reference your guides if you're looking for immunity versus even just the presence of the virus, because it can be, kind of alphabet soup in terms of how to navigate that. And,
yes,
kind of know that or refer out appropriately before you start having that conversation with the patient. And I think if you're not in a space that's comfortable to treat, then refer to somebody who is, to be able to navigate those waters. Because I think it can lead to some confusion on the patient's part. This one said this, and this one said that, and this one said I needed treatment, and that one said I didn't. And then that's another reason we may lose them to follow up. So
I agree. And, ASLD website's very good. The Hepatitis B Foundation Coalition is very good. Even World Health Organization, their websites are fantastic in regards to creating, cute little graphs that show you exactly what, surface antigen positivity, e antigen positivity mean. And, for someone who has been doing this disease state for 16 years, there isn't often time when I have to go back and look and say, okay, wait a minute, let's go back. He was this, this, and this, and now he's this, this, and this. What do I do? So I think even those that have been doing it a long time still have to reference these guides and these charts. So they're out there, Google if you really want to, but go to the right sites, obviously, and then ask those that you are comfortable asking who have been doing it a little bit longer, potentially. But yeah, no, I think all very good points. Anything else you want to add about hepatitis B?
Don't think so. It's been a great conversation. Thank you.
Okay. Well, I think we covered quite a few interesting topics, some good basic things about the stigma and helping navigate these weird conversations, particularly with chronic disease. Thank you for listening to us today. And of course, you can catch us on the GHAPP website or by downloading the GHAPP ACE app, where you can get this podcast and many other podcasts on many other diseases as well.